Now for the
Thank
next
you.
presentation, we have Dr. Tapan Ghose with us, and he will be enlightening us on heart failure with preserved ejection fraction and attempt to demystify. Dr. Tapan Ghose, he is the director at Fortis Flight Lieutenant Rajendra Hospital, director and head of cardiology. Dr. Ghose, please.
Thank you. So let me see whether I can demystify or not. So here is a case, 74 years aged lady who is diabetic, hypertensive, has a moderate CKD. She presented with breathlessness, and then her NT-proBNP was 550 picogram per ml, and the echo showed normal ejection fraction, and LVH with a E by E ratio of 10, left atrial volume index of 33. Is this patient in heart failure, preserve ejection fraction? So you can have a parallel processing and you can think and give us a diagnosis at the end. Let's see the evidence. Now, coming to the pathophysiology of systolic heart failure, this is the best cartoon I could make. The heart is very weak and the load is very high. And the road ahead contains rubbles, very bad. And that is what is the systolic heart failure as compared to diastolic heart failure, when a person is robust, thick heart, like a sumo player, but not able to perform properly because of inadequate relaxation. And the myofibers also quite big, long because of the hypertrophy and some changes in the interstitium. So these patients are having a situation of heart failure because of a maladaptive response, a very thick ventricle. Now, what the guideline says, the guideline, ACCH guideline for diagnosing of heart failure says that there could be, ejection fraction should be more than 50% along with sign symptoms, and borderline is 41 to 49, and heart failure with improved ejection fraction is more than 40. As compared to ESC guidelines, which is mostly used, you may have sign symptoms or only symptoms plus echo evidence of LV ejection fraction, which is more than 50%, and NT-proBNP elevation. The global prevalence of heart failure with preserved ejection fraction from different studies and registries is around between 30 and 50%. What about India? In India, 1 out of 4 heart failure patients have heart failure with preserved ejection fraction. The data comes from Trivandrum Heart Failure Registry. Most of them, in these patients are predominantly women, and men has lesser incidence. Much younger patients, at least 1 decade earlier. Hypertension is the commonest risk factor in this registry. Atrial fibrillation was present in 23% of patients, and more patients were on ACE and ARB. So in India, hospital readmissions at 1 year is 30% in this group. 30-day mortality is 12.5%, 3-year mortality remains 40%. Although the mortality at the end of 5 years is little less than 50%, but closely they resemble systolic heart failure in the long run. Pathophysiology, preserved ejection fraction primarily a disorder of pressure overload. And so it sets a tone of endothelial dysfunction, microvascular inflammation, cellular changes, cardiomyocyte change, and there is myocyte hypertrophy, increased titin phosphorylation, so interstitial changes, and then this leads to a situation where heart is not able to relax as a pump, and then the LV pressure, end-diastolic volume, and end-diastolic pressure is elevated, and that again is reflected in the clinical picture. And there is RAS activation and hormonal activation of heart failure. And not only that, these patients have abnormal coronary flow reserve. So that data comes from the PROMISE heart failure study. It showed that abnormal coronary flow reserve. So what is the pathogenesis? We have hemodynamic mechanisms of deterioration and the cellular and molecular mechanism of deterioration. So cellular, extracellular structural changes, cardiometabolic abnormalities, microvascular inflammation, left congestion, diastolic dysfunction, left atrial hypertension, LA enlargement, pulmonary vascular changes, and volume overload. And that's what we get clinically. Some data from Indian subcontinent. The patients of Indian origin, they have comorbidities which are less they have anemia, they have the obesity, and highest rates of concentric hypertrophy. This is what we see. Many often we see in the echo lab, our patients have concentric hypertrophy without, any much causes. That's actually area of concern that is consistent with our observation in the echocardiography lab also. There are some studies of phenotyping these patients of diastolic heart failure. That means these are not a homogeneous entity. There are aging phenotypes. These are the elderly patients. There is age-related hypertrophy. Some of them are hypertensive, and they have a heart failure with preserved ejection fraction. There is obesity phenotype. These patients are obese and they have a diastolic dysfunction and heart failure. Pulmonary hypertension phenotype. These patients, they have increased prevalence of pulmonary hypertension, which is disproportionate. And CAD phenotypes. Some patients, at least in 35 to 53 patients in large series, have coronary artery disease phenotype. That means you find that coronary artery disease is contributing to the diastolic dysfunction significantly, and you revascularize and you change the scenario. So coming to the comparison with reduced ejection fraction versus preserved ejection fraction, this is more common in women. There is alteration in the LV filling, history of hypertension, diabetes, and concentric remodeling, myocardial inflammation, little impact on LV systolic function. Now, how they behave, the data comes from I-PRESERVE study. Most of them are going to die from cardiac causes. 61% are CV deaths. What is the mode of death? 44%, majority of deaths will be sudden death. So we could identify that these patients are going to die from heart failure or cardiac causes, and they are going to die suddenly. And one of the important features is that, like systolic heart failure, if these patients keep on coming again and again to the hospital, that means there is increase in hospitalization that leads to increased deterioration, and that really is a marker of mortality. Signs and symptoms: third heart sound, pulmonary congestion, edema, hepatomegaly. It resembles a systolic heart failure. And clinical characteristics, majority will be women, and age 74 to 78 years. In our population, we can see it a younger age group. Hypertension, coronary artery disease, atrial fibrillation, diabetes, body mass index higher. These are the association as compared to systolic heart failure. Now, all the scientific societies, they really understand that there is a non-specificity of symptoms and signs, and that needs to objectify. That's why both the ESC and ACC guidelines, they recommend that you should really have some testing, further testing, and objective evidence of cardiac functional abnormality. Echo is the initial one. Then there is elevated levels of BNP or NT-proBNP. In patients where you do not get at rest, but any abnormality, then you can do a stress test or invasive measurements of LV filling pressure, and diagnosis is based on total assessment. Now, example, 75 years lady, dyspnea, NOH class 2, heart failure, preserved ejection fraction at rest. So you do, the LV mass index assessment more than 95 gram per square meter. So high LV mass. LA is enlarged. LA volume index more than 34. LA enlarged. Then there is evidence of diastolic dysfunction, and tissue Doppler imaging also shows E by E dash at more than 14, and that clinches the diagnosis of heart failure with ejection fraction at rest if you have signs, symptoms, and abnormalities. Now, always the detection of diastolic dysfunction related to exercise exposure. So a diastolic stress test can be performed with echocardiography, typically using a semi-supine bicycle ergometer. Parameters which will be assessed are LV, E by E dash, pulmonary artery pressure, systolic dysfunction by longitudinal strain, stroke volume, cardiac output changes with exercise. And here is an example. At rest, echocardiographic parameters: normal LV filling, mitral E by E dash less than 40, TR velocity 2.8. If you stress this patient, and this patient had elevated LV filling pressure, mitral E by E dash more than 40, 14, TR more than 2.8, TR velocity. So clearly this patient has features which suggestive of heart failure with preserved ejection fraction. So if the clinical picture is there, then this patient really has diastolic heart failure. cardiac magnetic resonance imaging, and MR has really made a breakthrough. It's a gold standard for the assessment of volume, mass of and ejection fraction for both the left and right ventricles. It's a preferred imaging method to assess myocardial fibrosis, with parameters assessed at tau, that means time constant of relaxation of the LV, characterizes early diastolic relaxation. Beta is assessed, the passive stiffness constant characterized to end diastolic pressure volume relationship. EC volume, the extracellular volume, which can be quantified, and that gives a fair assessment of that all the diastolic parameters. Coming to the invasive parameters, we have to demonstrate that there is increased in diastolic pressures. This is a cardiac catheterization example, both LV and pulmonary capillary waist pressure. If you look into, the pulmonary capillary waist pressure, it's 15, and the LVEDP is 15. After exercise, this is the pulmonary capillary waist pressure, 30, and LVEDP has gone up 30. So clearly, this patient has, stress-induced elevation of the LV and diastolic parameters, and this patient qualifies for calling LV heart failure with preserved ejection fraction. Now, some diagnostic scores. This is the data from Mayo Clinic, and they analyzed all these patients. 414 patients of non-cardiac dyspnea were analyzed, and they had 64% heart failure preserved ejection fraction. And these are the parameters, including all the parameters were analyzed, and they came with a score, and this is called H2F PEF diagnostic score. And H2 means heavy patient, body mass index, presence of hypertension, and if they are there, then you score 2. And then hypertension 1, atrial fibrillation score 3, and pulmonary hypertension, elderly patient, feeling pressure high, these are 1, 1, 1. You can have a sum of 0 to 9. So if you have a, say score of say 5, then you have 85% probability of having heart failure with preserved ejection fraction. Here is an example. So our index patient had a H2F-PEF score of 5. So she has more than 80% probability of heart failure with preserved ejection fraction. This was the index case. Now there is another score, ESC score or HFA-PEFF score, and this is a little cumbersome, and this is initial workup, pre-test assessment, symptoms, signs, ergometry, ECG, echocardiography, and NT-proBNP. Then next step is echocardiography and natriuretic peptide, and then advanced workup, exercise stress echo, hemodynamic exercise, hemodynamic assessment, etiological workup for ergometry, and then other imaging modalities. Then you can have a score. And this is a little cumbersome, probably reserved for the research purpose. You should have major criteria 2 points, minor criteria 1 point. And if you have more than 5 points by this criteria, ESC criteria, then you have heart failure preserved ejection fraction. Now there is a little dichotomy. Our index case has, this patient same. If you go by the criteria, then it has a score of 4. So as per the ESC score criteria, this does not fall into diastolic heart failure. They say that further workup is needed. So there is a little dichotomy. Now coming to therapeutics, these are the host of trials of ACE, ARB, and other agents, beta blocker, DIGE, spironolactone, enalapril, nebivolol, and everything, and including riociguat, and all were neutral. So at the present moment, we really don't have a answer to definitive answer to the management of these patients. Then what we do? See, all these patients should be assessed for cardiovascular and non-cardiovascular comorbidities. So we identify that and treat that. Diuretics remain the mainstay of treatment for heart failure with preserved ejection fraction and moderate ejection fraction also. Now, treatment of symptoms, diuretics remains number 1. Beta blocker, MRA, improved symptoms in these patients is lacking. So, we do not have a preference for any agent, but if the beta blockers are indicated, just coming, nebivolol has shown some effect on treatment, hospitalization. So nebivolol, DEEG, spironolactone, and candesartan has shown that they reduce the hospitalization. So these patients should receive a beta blocker like nebivolol, a candesartan, and a diuretic. Effect of treatment of mortality, so far we do not have any agent which increases the survival in these patients. So again, systolic and diastolic blood pressure should be controlled, diuretics, and revascularization is class 2A. If it is indicated, management of AF as per the protocol, beta blocking agents, ACE inhibitors, ARBs for hypertension is class 2A in this case. ARB might be considered to decrease hospitalization, class 2B. And in patients, if you want to reduce the hospitalization, you can add a spironolactone. However, routine use of nitrates, phosphodiesterase inhibitor, no effect, and national nutritional supplement is class 3, no benefit, should not be used. What's new is in the ACC.
Time is up actually.
Yeah, just give me a few seconds. I'll just complete. What's the new is, ACC HFA presentation, Paragon heart failure study. They studied the effect of secovitril valsartan. It showed that it reduces antipropanol by 19%. Antipropanol reduction similar in man, women. Antipropanol did not identify patients who benefit from secovitril valsartan. So summarize, heart failure with preserved ejection fraction is challenging to diagnose based on the ACC ESC guidelines. EF more than 50% and or EF while the ejection fraction is less than 40 is indicative of heart failure reduced ejection fraction. Transthoracic echo remains the mainstay of diagnosis in this patient, which should be supplanted by estimation of the NT-proBNP or BNP. Many complicated clinical trials are there, which there is an unmet need for therapeutics in these patients. Thank you. Thank you very much. We look forward.
Thank you.